Hi, everybody. I'm Dr. Achala Vagal. I'm a neuroradiologist by training, and I am professor of radiology at the University of Cincinnati. I have been working in the stroke imaging field for a long time now. I have the privilege of working with both researchers and clinicians in this field, and I have learned a lot from them and obviously our patients. So our topic today is CTP interpretation and pitfalls. So we're going to do a deep dive on CT perfusion. Here are my disclosures. So what are the learning objectives today? Well, number one, we're going to review how to interpret a CT perfusion in acute ischemic stroke. Number two, to understand technical and diagnostic pitfalls of automated CTP. And number three is to learn some of the key pearls in this interpretation. Most of you are already comfortable with the CT perfusion as we have started using them in these past few years in the treatment-making decisions for our acute ischemic stroke patients. But let's get into these learning objectives and learn from some of the cases that I have for you today. Before we get into the nitty-gritty, a 10,000-foot kind of a question. Why are we using perfusion imaging? So two main things. Number one, it helps us to understand what the core size is. And the other one, is there a mismatch? So we know that the core is the brain tissue which is irreversibly injured. And the penumbra is the potentially salvageable if the reperfusion happens in time. This is where the perfusion imaging can be very helpful. We also know that CT perfusion can help us with decision making. You and I have seen many of these cases in our practice now. Here is one case. This is an example of a mismatch. What I'm seeing over here is a small predicted core, that little red zone, which measures 5 cc, using a CBF, a relative CBF threshold of less than 30%. If we use the Tmax greater than 6 seconds, there is 155 cc's of penumbra, which, if everything else is working for the patient, which means there is a large vessel occlusion, the timing is correct, this patient is favorable for endovascular treatment based on the CTP. What about this example? Here we have a large core, almost 155 cc's, the entire right MCA is wiped out. Equally large penumbra. So this is a large predicted ischemic core and unfavorable for endovascular treatment just based on the CTP. Now, one thing I want to highlight, you will see that I'm using the term predicted ischemic core because we know that the CTP, although a useful tool, is helpful in predicting. Sometimes that might not be the true core. And of course, this is a whole complete, kind of a discussion. What is the true core? What is the predicted core? But for practical purposes, CTP does give us a gauge of a predicted core. Now, we all know the advantages of a fully automated perfusion software. It's fast, it's easy to use. It's also a computer-generated threshold map, giving us the volumes, which, by the way, we know they are better than visual assessments. As a radiologist, I can tell you I take great pride in saying that I can actually look at it and assess it. Unfortunately, no. There have been studies which show that humans are not very good in making visual assessments and coming up with volumes. So the CTP, a fully automated CTP software, can give us those volumes. Also, 24/7 automatic generation means efficient workflows, and these notifications happen over email, phone. Very importantly, the reason why we are using perfusion softwares in our clinical practice was that this was validated in multiple trials. We also know that there are multiple automated CTP examples, and multiple companies are actually coming up with their products. So depending on what you are using, and we will get into this later, it's really important to be comfortable and knowledgeable about your own software. So let's jump into the CTP interpretation. The question is, what do these CTP maps mean? And some of this is going to be basic, but I I always think that we should always start with the basics because they never go out of style. So the one basic that we are going to get into is how do we obtain the CTP and what is the technique? The images in the CT perfusion when the patient is on the scanner are repeated. It's a cine mode, which means that the CT scanner is basically looking at the brain again and again as the contrast is being injected. And what we are seeing is this dynamic flow as the contrast washes in and out through the capillary bed. What you're seeing over here is a time density curve. This time density curve is critical because based on that, that's where the mathematical models and in the background are helping to calculate the perfusion parameters. I will not go into the physics of this time density curve and what is happening, but just know that as the contrast washes in and out at a voxel level, that's where all these perfusion maps are being created. That's where the volumes are being calculated. So the contrast agent TDC, or the time density or the time concentration curves, is being generated in the arterial, in the venous, and of course at every pixel level. So you can see we are injecting contrast through the brain, and as the contrast is going in, we are creating these time density curves. The reason why I'm talking about this is this example over here, where we are actually seeing the parametric maps, is nothing but what was calculated based on the time density curve. So here are the four important things, right? We have the CBV, or the cerebral blood volume. This is ml per 100 grams. So it's the volume of the blood, depending on the volume of the brain tissue. CBF is the cerebral blood flow. It is ml per 100 grams per minute. So volume of blood in that volume of brain, but now we've got the time factor. The MTT, or the mean transit time, or the time to peak, or the Tmax, what we are used to, these are all time metrics. And Tmax is what we are using to calculate our Penumbra. I find these parametric maps very helpful, and I'll come to that. What we are more comfortable with, or rather I can almost assure you that 90% of us start looking at this, which is the CTP summary map. So let's just go over through this. What does this show you? Remember, we said the core, which is in the trials, they showed us relative CBF less than 30%. That's why we are using this threshold to get the main summary map. Here it is 3 cc, that little small red area, right? You have a bigger area of mismatch, or a bigger area of Penumbra, which is Tmax of 6 seconds. Again, these thresholds were used in the trials, like diffuse 3, Dawn, and that's why we are using it in the summary maps. And then you get a mismatch volume, mismatch ratio. So this is pretty easy, right? It's almost like the automated software is telling you what exactly to look at. It's giving you the volumes. There is not much of a kind of a difficulty in interpreting this. But what I would say is that there is so much more. So let's just go not just at the summary map, but something other pieces. So the other pieces of the CTP map are going to be these color scale source maps. I always like to look at them because visually it can tell you, like in this example, the CBV is decreased in that left anterior MCA, same thing with the relative CBF. And time to peak and the Tmax, it basically is increased. So you can see that this is an area of critical hypoperfusion. One more thing that is very helpful in our CTP maps is the different thresholds. So let's look at the Tmax thresholds. In your software, you're also getting these additional thresholds. Why are they important? Well, we know about the good collaterals and poor collaterals. So good collaterals, the first example over here, what it is showing me, if I look at my thresholds, that I've got a Tmax of 6 seconds of 55, but the other important Tmax threshold is the one at 10 seconds. So the hypoperfusion index, which is the HIR, which is getting a lot of attention now, and there has been quite a bit of literature about it, it is an indicator of tissue collaterals. And that is the Tmax of 10-second volume divided by the Tmax of 6 seconds. Remember, 10 seconds basically means that it is taking that much time, longer time for the contrast to come in. There is a large vessel occlusion. There is a lot of collaterals. There's all this circuitous route of the contrast agent, and that's what the Tmax is capturing, right? What is that delay? The other example is poor collaterals. And again, this is almost like a no-brainer. Look at that 10 seconds, all that red in that area of left MCA. And what that is telling me is the hypoperfusion index is high. I've got a lot of Tmax of 10 seconds. And when I look at a hypoperfusion index of 0.7, it tells me that at a tissue level, there are poor collaterals. So some of the papers have shown that HIR less than 0.4 is good collateral. So I use this for understanding tissue collaterals. Remember, you also have a CTA that's going to tell you the collaterals at a vessel level. What about the additional CBF thresholds? Remember what we said, 30% is what we use because that was used in the trials. But the software is also giving you 38%, 34%, 20%. And I will highlight some of the examples where these additional thresholds can help in problem solving. Because as you and I know, like medicine is never black and white. There are lots of grays, and we have to use every bit of information that is available. So let's look at a case and just try to put all this together. So here is an 89-year-old with left MCA syndrome, unknown onset, NIH stroke scale was 20. If I look at my CT angiogram, there is an occlusion of the left M1. It's got some collateral, some reconstituted flow coming into the left M2s and M3s. And I would say it's kind of a moderate collateral if I look at the CTA. Here is the CTP. We did this because it was unknown onset. We wanted to know what is the perfusion profile looking like. So you have a mismatch, but if I look at my Tmax thresholds, I can see that the hypoperfusion index is 0.1, which means that you have good tissue level collaterals also. This patient is favorable for endovascular treatment. We did take him to EVT. Here is the pre-EVT. You see a occlusion of that left M1. Post-endovascular treatment, vessel opened up, really good perfusion. Here is the discharge follow-up MRI, before discharge follow-up MRI. Few acute infarcts in that left MCA, and the NIH stroke scale of 5, and the patient walked out of the hospital. This is exactly what you and I basically want every patient to have an outcome. And that's why this field is so fascinating. And that's why I think CT perfusion can be helpful in making these decisions. Now, CTP pitfalls and pearls. So in our previous module, we looked at what are all the CTP maps? How do we interpret it? What do they mean? What does the time density curve mean? So we looked at some of the basics about the interpretation and what do the maps mean. Now let us get into some of the pitfalls and some key pearls. Remember, some of the things that we looked at was, oh, here is a great summary map. And it's almost the perfusion software is telling me everything that I need. But just like with any tool, there are going to be pitfalls. So CTP pitfalls, I like to divide it into two categories. One is technical and the other is diagnostic. And we'll look at both of them. So let's start with our technical pitfalls. This is a very famous radiology quote. Garbage in is equal to garbage out. What does that mean? Before you start looking at the summary maps, or before you even are thinking about using the summary maps for decision making, one of the pivotal things to do is check the technique. So I like to have a technical checklist of a perfusion study before I go into the summary maps and understanding the volumes, and to number one, ask myself, do I believe those volumes? Well, I want to check 3 things in my technique. Number one, is there adequate time density curve? Number 2, did the software pick the optimal arterial and venous input? And number 3, is there patient motion, or is it is it a lot of patient motion that I actually don't trust the CT perfusion maps anymore? So this is a technically adequate scan. What do I mean by that? Remember, we said three things. So this is the time density curve. What I want to see is a nice upslope and a downslope, and it coming to the baseline. And you can see that this is happening both in the AIF, or the arterial input, and the venous output function, okay? The x-axis, remember, is your scan time. It is this time as the perfusion is happening. The y-axis is the change in the CT attenuation. Remember what we said. As you inject the contrast, the machine or the scanner is scanning this part of the brain again and again. And so the attenuation of your CT contrast is changing. It's increasing and it's decreasing depending on the microcirculation at a capillary level. So I like this time density curve. Nice upslope, nice downslope coming to the baseline. Usually, you definitely want to have at least a 60 to 70 cc's of CTP scanning time. And this is where I would highly encourage all of you to work with your radiologist, work with your technologist, your physicist to set up the correct protocols. The second thing that I also want to see is, where did the software pick the arterial and the venous input? So over here is your arterial input in the A2s, and here is your venous input in the superior sagittal sinus. Motion, that's the other thing. You get these lines in the translational, rotational. You want to see straight lines. So these three things tell me that, yes, this was a technically adequate scan. Motion sometimes is very easy to detect on, if you look at this, there is a straight line, which means there is no motion. The other one, there is a little bit of motion. Now, we also know that most of the patients who come in as code stroke are unfortunately, can be quite sick, and almost 40% of them may have motion. So this is something that you'll have to deal with at a very common basis. So look at this scan. I mean, here again, quite a no-brainer, right? This is, plus the software is giving you this really big red warning, that CTP quality warning. But you can just look at this even without that warning message saying this looks abnormally like artifactual, right? I mean, you have everything bilaterally. This is something that you're going to be a non-diagnostic CTP. What about the contrast bolus? So one thing we saw was motion. So look at this case. This is a poor contrast bolus. And again, you've got a warning. You've got a red, CTP quality warning. I have started appreciating these warnings now. Again, remember, as a non-radiologist, you may or may not have all those cine images that we talked about. So you might not understand how bad some of the motion or some of the time density curves can be. So I think these warnings help us and to say, okay, I'm going to look at my technique again. Because if I just look at the summary map without that warning, nothing really looks bad in it, right? So I'm saying, okay, there is a 0 cc core and a 0 cc Tmax. But if you look at the time density curve, clearly it is abnormal. I've got a long baseline. It's trying to go up, right? There is a little bit of upslope, but really no downslope. So this is a suboptimal curve. Why are we talking about these time density curves? Okay, so let's just understand one thing. Number one, truncation, or the truncated curve, like in this example, right? You've got a nice upslope, but it never goes down. Number one, it is common in patients with large vessel occlusion. So don't be surprised as you start seeing it in a few patients. Number two is that this can result in overestimation of the core. So from this paper, here's an example of same patient processed differently based on their times. The first one is a 48-second. The second one is an extended 210 seconds, right? So you have got some extremes of the times of the CTP. You have a large core in the first one and no core. So if you have a truncated time density curve, or say for whatever reason, the protocol is at 45 seconds, or like in this case, 48 seconds, you could overestimate the ischemic core. So this is something really important to make sure. And just to take you back to that earlier module, remember where we talked about CTP interpretation, and I talked about why the time density curve is so important. The time density curve is the basic thing that the software is going to look at. And in the background, your mathematical algorithms are using the time density curve to calculate everything else, right? So we want to make sure that the TDC is not suboptimal, rather it's adequate. What about wrong arterial or venous input selection? So in this case, again, you've got a warning over here, something is off, the source data, maybe there is a bolus timing issue. If I look at where the software is selecting it, it is actually putting this red dot in the occluded artery. Ideally, it should be on the opposite side. And in my experience, the automated softwares do a really good job in selecting the venous and the arterial input. But sometimes you'll have a case like this. Again, you have to be really careful before you trust the CTP map, because this is a wrong arterial input selection. So in summary, technical checklist is the first thing that we should be doing before we start making decisions based on the CTP. Look for the time density curve, make sure you've got an adequate TDC, look at the arterial input, the venous input, and of course, look at the motion. So now that we have done our technique checklist, we will move on to the next module. Coming to diagnostic pitfalls. So in the first one, we saw how we are going to do the CT perfusion interpretation. The second one, we talked about the technical pitfalls. Now we're going to put it all together and see a few cases where we're going to see what are the common diagnostic pitfalls and what are some of the pearls. The first pitfall, over or underestimation of predicted core. Let's start with this case. 40-year-old, right MCA syndrome, NIH stroke scale was 20, came to the hospital 10 hours, last known well. If I look at my non-contrast CT, I can see that on the right side, I see asymmetric hypodensity, a little bit of hypodensity over here, the basal ganglia, the insular cortex, the caudate. So I know that there is early ischemic changes in this non-contrast CT. If I look at my CTA, there is a right MCA occlusion. The CTP was completely normal. The summary map showed no core, no penumbra. So one of the things we discussed is, remember we said we have additional maps. So the CTP summary map was normal. When I say normal, no core, no penumbra. I'm looking at my CBF, and I'm looking at the same area in the right basal ganglia. Right here, this is an area of hypoperfusion or decreased flow. This is underestimation of ischemic core. So here is the patient did go for an endovascular treatment, TICI-3, but the MRI a day later shows this area of infarct in that right MCA territory. And we see this many times, that there is this partial reperfusion. Remember, as the vessel is occluded, okay? In a large vessel occlusion, the CBF, the flow say decreases. The brain is going to do everything in its power to get flow back to that area, which means vasodilation, recruiting the collaterals. So there is going to be some partial reperfusion there. What that means is this previous area where it did not pick it up. Remember, we said the only way it picks up if the threshold meets that 30% criteria. But here, the non-contrast CT was already showing us that, yes, there is already core that is setting in. So remember this phenomenon of partial reperfusion. Here's another example. 55-year-old left MCA occlusion, last known well, 14 hours. This was a transfer patient, which means we did not have any of the CTs or the CTA. Patient basically had only CT perfusion in our center and the other baseline studies outside. If I look at my CTP over here, I've got a small core, I've got a large penumbra, but I'm also looking at the other images that are available. I can clearly see that there is more in that left MCA that seems that there is hypodensity, which somehow the CTP is not capturing. This is underestimation of the ischemic core. I'm also going to look at the different thresholds. Remember, we have additional thresholds. If there is a discrepancy, I would highly recommend look at all your thresholds, because this is where you actually have that conversation with your interventional team, right? So if I look at my CBF of 38% and I Tmax of 6 seconds, that's almost a match. This patient did go for endovascular treatment, and they actually had a really good reperfusion, TICI-3. But look at that follow-up MR. It is actually showing that same area of infarct that matches with CBF of 38%. And I'll come to why we have chosen the CBF of 30% and how it makes sense. But again, think about the different thresholds. Again, here it is underestimating the core. One more really important in this core under or overestimation I would like to highlight is this concept of post-infarct core, particularly for those of you who are doing CT perfusions in the early windows. Okay, so this is a great example, and here the group highlighted this case where the CT looks really normal, aspects of 10. So really good, there is really no hypodensity, aspects of 10. Look at that CT perfusion performed at the same time. This was an early window, and it looks completely abnormal. There is this huge, large area in the right MCA, which does not match with the non-contrast CT. So there is clearly a discrepancy between the non-contrast CT and the CTP. The patient was taken, there was a TICI-2B, and you can see the follow-up head CT. There is really no core. This is a really great example to show us that we have to be careful about this ghost infarct core. And let's just see why, when we're talking of the CBF threshold, I want to highlight something. What is the optimal CBF threshold for ischemic core? Now, this study actually showed us that the CBF of 38 or less than 38% relative, right, best optimizes the mean volume difference between the CTP and the DWI, and that the CBF 30% is underestimating the DWI. But importantly to note, this is a less restrictive criteria. We have an incredibly efficacious treatment for endovascular treatment, and we don't want to deny it to patients based on very restrictive criteria. So the CBF of less than 30% is less restrictive, but that's exactly how it is intended to be used so that we can offer this treatment. But just so that you know at the background that CBF of 38% is the best optimal one, at least by this paper. Now, we also know the one that I showed you, the ghost core. This overestimation of core in ultra early perfusions has been shown in papers. And in this paper by Bivard and their group, basically what they said was, if you look at CBF of less than 20%, that might be a more accurate threshold for the ultra early reperfusions. And so if you are a group that is doing CT perfusion for all patients, particularly in your early time windows, be careful of this overestimation of core. Here is an example that we had. 61-year-old with code stroke, last known well for 2 hours. We usually at Cincinnati are not doing CT perfusions for the early windows. We do it for greater than 6 hours or last known well is unknown. But for some kind of different reason, this patient did get a CTP. So I'm going to go over some of this tough case, if you may. So this is a 61-year-old. I'm looking at the non-contrast CT, and I can see that there is some hypodensity in the left MCA. The left caudate looks a little hypodense. There might be something in the insular cortex, again, above the supraganglionic level. I've got some areas of hypodensity. This is an aspect of 6. CTA shows a left M1 occlusion, okay? So if I look at just the non-contrast CT, I don't think it's a bad looking. It's a pretty good looking, aspect 6. But look at that CT perfusion. The CT perfusion is showing me that the predicted core is large. It's 166 cc. And again, those maps are showing that this is a really large area of core. So CT, non-contrast CT would have been favorable. We've done the CTP, which is unfavorable. what kind of decision do we make? Do we take them for endovascular treatment or no, right? And this can be a difficult decision, particularly, like I said, if you're doing it in early time windows. Well, what about the other maps? Can we use that? Is this overestimation of the core? So let's look at the other Tmax. Now, remember, we talked about the Tmax and using the hypoperfusion index as to understand the tissue collaterals. So the hypoperfusion index over here is 0.7. This is poor collaterals. I can see a lot of reds or a lot of Tmax of 10 seconds in that area. And the CBF, if I look at the different thresholds, if I decide to use that 20% threshold, because this is in that early, couple of hour windows, that's a 30 cc. I go up to the 30% threshold, I get 166 cc. This is really important to know that sometimes if these thresholds are moving this fast, you have to be careful. And that's where, again, you can have a conversation with your stroke team, with your interventional team, and of course, very importantly, with the patient and family. So this was the CTA, left MCA occlusion, and then you have a CTA source images, again, showing an area of really poor collateral. So just looking at this, we know that this has got poor chances of survival. We did take this patient for endovascular treatment because this was a relatively healthy patient. And again, this is an efficacious treatment. Unfortunately, it was failed, EVT, TICI of 1. This is the follow-up CT. So the reason I'm showing these multiple examples is that here are a few key points when we think about core. CTP is only a snapshot in time, which means that there is a lot of dynamic things that are happening. And the CTP is one point in time. It is critical to review all the studies of your code stroke, which means non-contrast, the CTA, the CTA source images. I find them incredibly helpful. The CTP output map, especially for transfer patients, if you don't have the rest of the imaging right in front of you. And also review the additional CBF thresholds as that are available to you. Moving on, pitfall number 2, misclassification of penumbra or mismatch. So this is a 42-year-old with IV drug use, known previous infarcts, now comes with right-sided weakness. And we actually have written up this paper, written up these pulls and pitfalls, and we actually showcase this case in that because I think it's a really informative case. So here that, at that time we used to also do 2 slabs. So sometimes if your scanners are a little older, you have to do 2 slabs to cover adequate amount of brain, and then you have to calculate the CTP based on both the slabs. So if I look at my CT perfusion over here, I have, if I look at just the volumes, my total CBF is 76 ml. My Tmax is 208 and my mismatch is 2.8. So clearly, just by volumes, this is a mismatch. But obviously, we can see that the CTP is somehow also calculating the right-sided penumbra. This is a bilateral penumbra. If I just look at my left MCA, this is a match defect. Now, why am I seeing the right-sided penumbra? And the answer is, remember the history, we said that the patient had previous infarcts. So there are previous infarcts on the right side. The left MCA is the one which is more acute, the stroke event. And here is the CTA. This is a chronic right ICA occlusion, but patient unfortunately also developed an acute thrombus in the left ICA. But as the CTP is calculating, you're getting a Tmax, which is from both sides. So beware of these additional areas of Tmax that are calculated and can skew your numbers of the mismatch ratios. We did not do endovascular treatment for this patient, and this is the follow-up MRI, with the infarcts already, again, kind of declared in that left MCA. CTP in chronic occlusion. Here is another example. So the CTP, if I look at it, the summary maps, no core, small Tmax in that right side. If I look at the rest of the thresholds, there seems to be a larger area of the penumbra on the right side. This is a chronic occlusion. The reason I'm showing this to you is that do remember, in a chronic occlusion, you are going to get a hypoperfused tissue, which means your Tmax is going to be abnormal. This is another example. This is a patient, in fact, it's a preoperative CT perfusion for EC-IC bypass. So this is not even in acute code stroke. But if I look at my CBF and time to peak maps, they're clearly abnormal. The CBF is decreased, and there is a large area of abnormal perfusion. It is critically hypoperfused in that time to peak. So chronic occlusions can really impact how your Tmax can look like. So the key point over here is that any limitation to the upstream arterial flow, whether it is carotid stenosis, chronic occlusion, cardiac arrhythmias, aortic dissection, all of them can overcall your penumbra. So be careful before you assign all that penumbra to that acute code stroke event. Pitfall number 3. It's really not a pitfall, to be very honest, but it's something that all of us should be aware of, that there are differences in softwares. So you might already have an experience in multiple softwares, or if you are training in one institution, you go into another institution, they have another softwares. CTP maps generated by the different softwares are going to be different. And this is an older paper. This was published in 2010, but there also you can look at, they actually looked at 6 different commercial softwares for perfusion, A to 5 different softwares, A to E. And they showed that really the software, depending on what you're using, your maps can be different. So this is not new. This is not news. Different softwares are going to generate different maps because there is incongruence among some of the different softwares. There is also limited generalizability. And of course, there are propriety issues of black box, right? There is going to be vendor variability. So here is an example. And at our institution, we actually, looked at a couple of these softwares. So this is the same patient. So same CTP study processed by 2 different softwares. Software 1 is giving me a large core, large penumbra. Software 2 is giving me the similar kind of an appearance. This seems like a large predicted core and almost like a match defect. Now, if I look at the exact volume, the software 1 is saying 155 cc's of CBF, the other one is 172. The volumes, the actual numbers are not going to match, period. Remember, we said there is going to be vendor differences. Here is another example where I see software number 1 showing me a core, software number 2, the core is 0. So the bigger question in our mind was not whether my volumes match and which software is more accurate, but the bigger question was, are these clinically significant differences? Do I trust my software? Do I have the understanding of the software that I can make a confident decision towards the treatment plan, right? So are these differences clinically significant? And we did a small study on this, do they matter clinically? And this was, like I said, it was a small study. So we had 47 patients that we analyzed using 2 different softwares. And we found that really the clinical impact for endovascular decision may be minimal. So if I use the diffuse 3 criteria and if I use the Dawn criteria, the softwares helped us come to the same decision for the majority. So the decision impact, the clinical impact may be minimal. Here is another example where you have the software 1 giving you 86 cc's of core, software 2 is giving me a 52 ml. And again, what does, before you kind of make this decision, the question is, remember what we said, you have to check your technique. And I can see over here, both softwares are correctly showing me that there is a truncated time density curve. I've got a baseline, I've got an upslope, but there really never goes down into a downslope. There is also motion. And then, of course, your arterial input. Software 1 is showing me that the arterial input is correctly placed. It's on that left side, which which looks normal in the vessel, and the software 2 has picked on the right side. So again, these are all these extra tools that you have. And here was the non-contrast CT of that patient. The CTA shows you a right M1 occlusion. The source images also many times can be helpful. What I like to call is your CTA source images are your poor man's perfusion. So if you cannot trust your perfusion map because of motion or technical inadequacy, or if you want to make another checklist, do look at that CTA source images. I use them all the time. Here's the parametric maps, and you can see this large area of infarct in the DWI follow-up. So the key point over here that I would implore you is to be familiar with your own software, whatever your institution is using, because different post-processing algorithms are available. And again, I will not go into the physics, but just know that there is this singular value deconvolution, whether it is delay sensitive, whether it is delay insensitive, whether it is delay dispersion corrected, or there is Bayesian. What is the algorithm that's being used? And you should definitely talk to your radiologist, because they will understand at the back end what kind of algorithms are being used. And the optimal thresholds may be specific to particular software and versions. So in summary, I think as you look at your perfusion maps, here are some key imaging tips. Technical adequacy should be your number one thing to check. Do not focus solely on automated CTP outputs. Interpret your CT perfusion with the clinical history, non-contrast CT, and CT angiogram. Look at the additional CBF Tmax thresholds and know your own perfusion software. For all the pitfalls and the pearls that I talked about, I do want to say one thing. CTP is a useful tool. It can definitely give you useful information in the code stroke to make these important decisions. But in the era of automation, I think that's when you get this map on your phone on a single simple click. I think it's all the more reason that there is human interaction. The clinician, your radiologist input is going to be critical in the era of automation. Thank you very much.